Welcome to The Deep Dive, the show where we distill complex topics into truly fascinating insights, giving you the shortcut to being well informed. Today, we're plunging into a world where knowledge isn't just power, it's literally life or death. The intricate landscape of medical practice.
That's right.
You see, while doctors obviously need to know an encyclopedic amount of facts, the true mastery, the really critical skill that separates the good from the great, lies not just in what they know, but profoundly in how they think, how they reason, and how they make life-altering decisions under immense pressure.
Exactly.
The process. We're talking about clinical decision-making.
Mm-hmm.
This isn't just about memorizing symptoms or drug dosages. This is arguably the single most critical skill for physicians in the 21st century. And here's where it gets truly eye-opening and, frankly, a bit sobering. Our sources reveal some surprising statistics.
They really do.
Diagnostic error, meaning getting the diagnosis wrong or missing it entirely, is estimated to occur in a staggering 10 to 15% of cases in common specialties like emergency medicine, internal medicine, and general practice.
10 to 15%. Think about that.
Up to 1 in 10 patients receiving care in these fields might initially be misdiagnosed. Even more concerning, these errors are associated with greater morbidity, meaning more illness, more adverse outcomes, and sometimes tragic consequences than other types of medical error.
And crucially, the vast majority are preventable. That's the key takeaway.
So our mission today, your mission with us, is to unpack the intricate principles of clinical decision-making. We're going to explore its foundational elements, dive deep into the common pitfalls that can trip up even the most experienced clinicians, and uncover the precise strategies they employ to improve accuracy and ensure patient safety.
Yeah, get into the nitty-gritty.
By the end of this deep dive, you'll truly master this information, understanding the nuances of medical thought like the elite professionals in this field. Our core source material for this journey comes from carefully selected excerpts from Davidson's Principles and Practice of Medicine, a highly authoritative and universally respected text in the medical world.
It's precisely how counterintuitive those diagnostic error rates can seem, isn't it? Especially when we consider the sheer volume of knowledge doctors are expected to possess.
Absolutely.
This isn't about a lack of raw information or intelligence, but rather, as you hinted, about how that information is processed, integrated, and then acted upon. It speaks to the intricate cognitive processes at play, often beneath the surface.
The how, not just the what.
Throughout this deep dive, we'll peel back those layers, exploring not just the interpretation of diagnostic tests, but also the pervasive and often subtle influence of cognitive biases that affect all human decision-making, not just in medicine.
That's a really important point. It affects everyone.
I think it does. We'll also examine the critical role of human factors within the demanding, often chaotic clinical environment. These are the other elements of clinical reasoning that go far beyond rote clinical knowledge. Ultimately, our goal is to provide you with a robust framework to truly understand how complex medical decisions are made, and critically, how errors can arise, even when all the necessary pieces of the puzzle seem to be present. It's about understanding the art, not just the science.
And that's precisely where the deep dive truly begins, isn't it? Because understanding those cognitive processes, those habits of thought, is the very foundation of how doctors make decisions, going far beyond just what they learned in medical school. So let's start there. Clinical reasoning describes the entire thinking and decision-making process inherent to clinical practice. It's that crucial ability a clinician has to make informed decisions, often collaboratively with others, based on all the available clinical information.
All of it, yeah.
And what's truly fascinating is that our understanding of this complex process isn't just confined to the bedside. It draws vital insights from interdisciplinary fields like education, cognitive psychology, and even broader studies of expertise.
It's a real melting pot of disciplines feeding into this.
Our source provides a fantastic visual in Figure 1.1, illustrating the different elements that weave together to form clinical reasoning. Picture it like a complex dynamic system. At its bedrock are fundamental clinical skills. That's your meticulously taken patient history and a thorough physical examination.
The basics, but crucial.
On top of that, you layer on understanding how to effectively use and interpret diagnostic tests. But it doesn't stop there. Beyond these, a clinician must grapple with understanding cognitive biases and human factors, essentially, recognizing how the inherent quirks of the human mind and the environment influence judgment.
The mental game and the environment.
And a truly crucial element is the ability to think about thinking. to be metacognitive about your own decision process, to be aware of your own cognitive pitfalls.
Self-awareness, yeah.
Finally, it profoundly integrates patient-centered evidence-based medicine and shared decision-making, ensuring the patient's unique context, values, and wishes are at the heart of every choice. It's a holistic approach.
And that visual perfectly underscores the point that while clinical knowledge is absolutely necessary, it's definitively not sufficient on its own for good performance and safe patient care.
Right. Knowledge isn't everything.
That 10 to 15% diagnostic error rate we mentioned earlier, coupled with its association with greater morbidity, is a powerful indicator that something more is at play. The majority of these errors, while preventable, often stem from issues in reasoning. Not just a simple lack of facts or intelligence, it's about how the facts are used.
Okay, so let's break that down. What are the main reasons errors happen?
Our sources break down the three main reasons for diagnostic error, and these are crucial to understand. First, there are knowledge gaps. This isn't always about a doctor not knowing anything about a condition, but sometimes a specific, subtle nuance is overlooked.
Like a tiny detail missed.
Exactly. For instance, box 1.2 gives a really pertinent example. Telling a patient she cannot have biliary colic because she has had her gallbladder removed, gallstones can form in the bile ducts in patients who have had a cholecystectomy.
Ah, okay. So you think, no gallbladder, no problem, but that's not quite right.
Precisely. The immediate intuitive thought is no gallbladder, no gallstones. But the nuanced knowledge is that stones can still form in the bile ducts themselves, even without the gallbladder. Missing that specific piece of anatomical or physiological detail can lead to a completely missed diagnosis and ongoing suffering for the patient.
That's a really clear example of a knowledge gap. What's the second reason?
Second, we encounter the misinterpretation of diagnostic tests. This is another area where, even with all the right data, the reasoning can falter due to a misunderstanding of the test's limitations or context.
So you have the result, but you read it wrong, or misunderstand what it means.
Sort of. The source illustrates this vividly with deciding a patient has not had a stroke because his brain scan is normal computed tomography, and even magnetic resonance imaging, especially when performed early, may not identify an infarct.
Wow. So a normal scan doesn't always mean no stroke.
Especially early on. This is a critical nuance. A patient might present with classic stroke symptoms, but if an early CT or MRI is performed within the first few hours, the ischemic changes in the brain might simply not be visible yet on the scan.
Okay.
Interpreting that normal scan as a definitive exclusion of stroke is a misinterpretation of the test's performance characteristics in the early stages of a condition. The error isn't in lacking knowledge of stroke, but in misunderstanding the test's temporal limitations.
I see. That's subtle, but potentially devastating. And the third reason?
And third, setting the stage for a deeper dive later, are cognitive biases. These are often subconscious shortcuts our brains take to process information quickly, but they can systematically lead us astray.
Mental shortcuts.
Yeah. A simple example given is accepting a diagnosis handed over to you without question, the framing effect. Imagine a colleague tells you, this patient has X. Your brain, seeking efficiency, might automatically frame your subsequent thinking around X, rather than critically asking yourself, what is the primary evidence that supports this diagnosis? And perhaps more importantly, what else could it possibly be, and why might that initial diagnosis be incorrect?
You just take their word for it, basically.
Exactly. And if we connect this to the bigger picture, these specific reasons for error tie directly into the broader categories of diagnostic error outlined in box 1.1. At one end, you have no-fault errors, which might happen due to a truly unusual presentation of a disease or genuinely missing information.
Right. Sometimes it's just unavoidable.
Then there are system errors, which point to problems within the healthcare system itself. Inadequate diagnostic support, test results not being available in a timely manner, error-prone processes, poor supervision, or inadequate team communication.
Problems with the system itself.
But it's the human cognitive error category, which encompasses inadequate data gathering and reasoning errors, where our deep dive today truly focuses. The source makes it crystal clear. Errors in clinical reasoning play a significant role in the majority of diagnostic adverse events.
So it really comes down to the thinking process most of the time.
It's a core challenge for even the most brilliant minds in medicine, and it's why understanding how to think is as important as what to think.
That's a powerful breakdown because it really emphasizes that the problem isn't always about missing a rare disease. It's often about how information is gathered and processed, even for common conditions. So let's pivot now to the practical side of data gathering, the very tools of the trade.
Okay.
Even with all our incredible technological advancements in medicine, the fancy scanners and sophisticated lab tests, the enduring importance of basic clinical skills cannot be overstated.
Absolutely fundamental.
In fact, our sources explicitly state that the history remains the most important part of clinical decision-making. Think about that for a second. Studies show that physicians make a diagnosis in a remarkable 70 to 90% of cases from the history alone.
70 to 90%, just from talking and listening.
That's before a single blood test is drawn or a single scan is ordered.
It's quite something.
And it's not just about what the patient tells you directly, important as that is. The breadth of information gathering is crucial. It means seeking information from all available sources, always with patient consent, of course.
Right, you need the full picture.
This could mean reviewing notes from paramedics, poring over emergency department records, speaking with eyewitnesses, or even gathering crucial details from relatives and carers who might have observed key changes or symptoms the patient can't recall or communicate effectively. It's about building the complete picture.
Triangulating the information.
Beyond just gathering raw information, clinicians need to be acutely aware of the diagnostic usefulness of clinical features in both the history and physical examination. This goes way beyond simple textbook descriptions.
It's not just ticking boxes.
Take meningitis, for example. We're all taught the classic triad: headache, fever, and meningism, which includes things like photophobia and neutral rigidity, or neck stiffness.
The classic signs.
But what's vital for elite clinical reasoning isn't just knowing what these features are, but understanding their frequency in actual patient populations, and even more critically, their diagnostic weight. How much do they really point towards the diagnosis?
Okay, so diagnostic weight. How is that measured? You mentioned a surprising finding about meningitis.
Yes, exactly. How do doctors actually quantify that weight?
Absolutely. This is where we introduce a powerful concept. Likelihood ratios, or LRs. These are essentially clinical diagnostic weights that help us understand how much a particular finding, a symptom, or a sign increases or decreases the probability of a disease.
Okay, so a number that tells you how important a finding is.
Pretty much. An LR of greater than 1 tells you that the finding increases the probability of a disease. The higher the number, the greater the increase. Conversely, an LR of less than 1 decreases the probability. If it's around 1, it means the finding doesn't significantly change the probability either way. It's neutral, diagnostically speaking.
Got it. So back to meningitis.
And this is where that surprising detail about meningitis comes in. A prospective study on adults with suspected meningitis revealed that classic signs like Kernick's sign, Brudzinski's sign, and neutral rigidity, the neck stiffness we often associate with it, actually had LRs of around 1.
Around 1. So they didn't really help much in diagnosing it.
In terms of shifting the probability significantly, no. What it means in practice is they carried little diagnostic weight in that specific context. Figure 1.2 in our source actually shows this visually.
Wow, that really does challenge common assumptions, things you learn as absolute signs.
Exactly. While these are classic signs you learn in medical school, their presence alone might not be as definitive as one might instinctively think in either excluding or confirming the diagnosis, especially if the prior probability of meningitis is already very high or very low.
So you can't hang your hat on just one sign.
You really can't. It underscores why clinicians must take all the available information into account. You can't just rely on one classic sign to rule a disease in or out. This practice of incorporating knowledge about disease prevalence and the diagnostic weight of clinical findings into every history and examination is what's known as evidence-based history and examination.
So it's about being smarter with the information you gather.
It's about being smart and efficient with every piece of data, understanding its true value.
That insight about likelihood ratios and meningitis is a perfect example of how clinical reasoning pushes beyond rote learning into nuanced understanding. It highlights that normal isn't always normal and classic signs aren't always definitive. And this applies even more so to diagnostic tests themselves. What's compelling to consider is that there's no such thing as a perfect diagnostic test. This is a fundamental concept often misunderstood by those outside of clinical practice.
Yeah, that's a big one.
Tests give us test probabilities, not absolute real probabilities. Think about it. A positive test doesn't necessarily mean you have the disease, and a negative test doesn't always mean you don't.
Probabilities, not certainties.
Test results are inherently imperfect, and their interpretation is influenced by 5 critical factors. Can you walk us through those?
Absolutely. These factors are crucial for truly mastering test interpretation. First, let's consider how normal is defined. Most quantitative tests provide numerical results. By convention, the normal range is typically defined as encompassing 95% of the population.
The standard bell curve idea.
Exactly, which corresponds to two standard deviations above and below the mean. Figure 1.3 shows this. This means that, by definition, 2.5% of perfectly healthy people will naturally have results above this normal range, and another 2.5% will have results below it.
So 5% of healthy people are abnormal by definition.
Precisely. So that normal range isn't a definitive boundary of health or disease. It's more accurately a reference range, indicating a statistical reference point, not an absolute.
Okay, that's factor one. What's next?
Second, and this is a crucial aha moment for many, is the nuance of normal results in context. Sometimes normal can be abnormal, and abnormal can be normal.
Okay, unpack that one.
Take, for example, a normal PaCO2, the partial pressure of carbon dioxide in arterial blood in a patient experiencing a severe asthma attack. While the number might fall within the typical normal range in the context of severe asthma where a patient is struggling to breathe intensely, a normal PaCO2 is actually abnormal and signals a life-threatening condition.
Because they should be breathing fast and blowing off CO2?
Right. It means they're no longer compensating by hyperventilating. Their respiratory muscles are fatiguing and failing. Conversely, a low ferritin level in a young menstruating woman, while statistically outside the normal reference range, is often not considered a disease.
So low iron, but expected in that context.
Yes, it's a common physiological adaptation to menstrual blood loss and increased iron demand, rather than an indication of pathology needing aggressive intervention. The key is that normal is always contextual and must be interpreted alongside the patient's unique situation.
Context is king. Got it. Factor three.
Third, we have factors other than disease that influence test results. This is a deep rabbit hole of nuances that can significantly mislead if ignored. Think about pregnancy. This is a fascinating physiological state where many tests are affected due to profound bodily changes.
Right, everything changes during pregnancy.
For instance, due to hemodilution, an increase in blood volume substances like urea and creatinine can be reduced. There's an increased demand for iron, leading to physiological iron deficiency anemia. The placenta produces alkaline phosphatase, so its levels might be naturally increased. Physiological changes in the coagulation system mean raised D-dimer levels, a test often used to rule out blood clots, are normal in pregnancy. Even ECGs can show changes like tachycardia.
So all those abnormal results are actually normal for pregnancy.
Correct, but they would be abnormal in a non-pregnant individual. Another critical example is spurious, or in vitro results. Sometimes the problem isn't the patient or the disease, but the blood sample itself.
Like something went wrong with the sample handling.
Exactly. A high potassium level, known as pseudohyperkalemia, can be seen if the blood sample undergoes hemolysis, where red blood cells burst in the test tube, not in the patient's bloodstream releasing potassium. Similarly, very high platelet counts can cause this. A clinician needs to recognize these non-disease factors to avoid misdiagnosis.
Okay, that's a lot of non-disease factors. What's number four?
Fourth, operating characteristics profoundly influence test interpretation. This refers to the way the test is performed. Some tests, like spirometry for lung function, require full patient compliance and proper technique. If a patient can't perform it correctly, the result will be unreliable.
If the patient doesn't blow hard enough, the test is useless.
Pretty much. Other tests, like ultrasound of the heart or abdomen, are highly dependent on the skill of the operator. The patient's body habitus, e.g. obesity, can make it harder to visualize structures, and their clinical state.
So the person doing the test matters, and the patient's body type too.
Definitely. A common yet critical mistake here is when doctors report a scan as no abnormality detected, when in reality, the report explicitly described a technically difficult and incomplete scan that should have been more accurately described as non-diagnostic.
Ah, so they say clear when it actually wasn't a clear view?
Precisely. The test couldn't adequately rule out a problem, but the phrase implies it did. Very misleading.
Okay, and the fifth factor?
And finally, a crucial point about paroxysmal conditions and incidental findings. Some conditions are intermittent or only manifest during certain periods. For example, around half of patients with epilepsy will have a normal standard electroencephalogram, EEG, because the electrical activity associated with a seizure might not be present at the time of the test.
So a normal brainwave test doesn't rule out epilepsy?
Correct. So a normal EEG does not exclude epilepsy. Conversely, about 10% of people who don't have epilepsy will show epileptiform discharges on their EEG. This is an incidental finding, something unexpected, but not necessarily pathological.
So you find something weird, but it doesn't actually mean anything.
It might not. These incidental findings are becoming more common with increasingly sensitive imaging. The overarching principle here, and it's vital for elite decision-making, is that test results should always be interpreted in the light of the patient's history and physical examination. Context is king, always.
That's incredibly insightful, the distinction between test probabilities and real probabilities, and the myriad factors influencing test results truly highlight the complexity. So how do clinicians actually measure a test performance? We hear terms like sensitivity and specificity thrown around, but what do they truly mean for a patient?
Yeah, those terms are key.
And how does that trade-off influence how doctors choose and interpret tests?
Those are absolutely fundamental questions. Let's talk about sensitivity and specificity. Sensitivity is a test's ability to correctly identify those with the disease. These are what we call true positives.
Okay, catches the people who have it.
Specificity, on the other hand, is its ability to correctly identify those without the disease, the true negatives.
Right, correctly clears the people who don't have it.
Understanding these is essential for any medical professional. Here's the implication. Even a very good test, say with 95% sensitivity, will still miss 1 in 20 people who actually have the disease. That's a false negative.
1 in 20 still missed.
And conversely, every test will inevitably produce false positives, where the test indicates disease but the person is actually healthy. Box 1.4 in our source illustrates this with a simple table, showing the 4 possible outcomes of a test. True positive, false negative, true negative.
So no test is perfect, always some false results. What about the trade-off?
And there's always a trade-off. Imagine a tightrope walk. A highly sensitive test is designed to detect most disease, meaning it minimizes false negatives. But because it's so eager to catch everything, it might also generate more abnormal findings in healthy people, more false positives.
Catches more sick people, but also flags more healthy people.
Exactly. So a negative result from a highly sensitive test can reliably exclude the disease, making it a great rule-out test. But a positive result doesn't necessarily mean you have it. It simply means further evaluation is needed.
Okay, negative is good, positive needs more work.
On the flip side, a very specific test might miss some cases of pathology, meaning more false negatives, but when it's resulted positive, it's highly likely to establish the diagnosis beyond doubt, making it a great rule-in test.
Less likely to catch everyone, but a positive result is very trustworthy.
Precisely. It's all about what you're trying to achieve with the test and what the stakes are.
Can you give an example of this trade-off?
Our source gives a great example with the exercise electrocardiogram, or ECG, used to detect coronary artery disease. If you define an abnormal result as even a small ST depression, say 0.5 millimeter, you'll catch almost every case of coronary artery disease, making it highly sensitive.
Setting the bar low.
But you'll also get many false positives, sending healthy people down a rabbit hole of unnecessary, often invasive tests. If you set the threshold higher, say 2.0 millimeters of ST depression, you'll still detect most important cases of coronary artery disease, but with far fewer false positives.
Setting the bar higher gives fewer false alarms.
Right. This trade-off between sensitivity and specificity is beautifully illustrated by the receiver operating characteristic, or ROC curve. Figure 1.4 shows this. The closer that curve lies to the top left corner of the graph, the more useful the test is at discriminating between those with and without the disease. It's a powerful visual tool for understanding a test's real-world performance.
So we're always balancing the desire to catch every case with the risk of sending healthy people down that rabbit hole of unnecessary tests. It's a constant tightrope walk for clinicians.
It really is.
But here's where it gets really interesting and ties back to why a test result is never just a simple yes or no. The extremely important concept is that the probability a person actually has a disease after a test depends on 3 things: their pre-test probability and the test's sensitivity and specificity.
This is fundamental. Post-test probability.
Can you give us an example to make this concrete? How does pre-test probability change things?
Absolutely. Let's take the example from our source. An elderly lady falls and hurts her left hip. She has severe pain and can't stand. Her hip x-rays are reported as normal. Now, does she have a fracture?
Seems like no if the x-ray is normal.
But it's not that simple. Plain x-rays for a suspected hip fracture in the emergency department have a sensitivity of around 95%. So a small percentage of fractures are missed.
Oh, so the test isn't perfect.
Now, consider 2 hypothetical patients. Patient A is like Our Lady, but she's at high risk of osteoporosis, has severe pain on movement, and cannot bear weight. Her clinical pretest probability of a hip fracture based on her symptoms and risk factors is very high, maybe 90%.
Okay, very likely to have a fracture before the test.
If her x-ray is normal, that 95% sensitivity means the test still misses 5% of fractures. So even with a normal x-ray, because her pretest probability was so high, there's still a significant 34.6% chance she does have a fracture. Figure 1.5 illustrates this shift. The normal x-ray hasn't actually ruled out.
Wow, still a 1 in 3 chance even with a normal x-ray.
Now imagine patient B, someone unlikely to have osteoporosis, perhaps the younger person who only has mild pain on hip movement and can bear weight. Their pretest probability of a fracture might be only 50%.
Lower chance to begin with.
In this case, a normal x-ray drastically shifts that probability, making a fracture very unlikely, only a 5.6% chance. This illustrates a profound and subtle principle of clinical medicine, articulated by Sachs and colleagues. The interpretation of new information depends entirely on what you believed beforehand.
What you thought before the test really matters.
Critically, the test result shifts the probability, but it doesn't always definitively confirm or exclude, especially when the pretest probability is very high or very low.
Okay, so that pretest probability is vital. How do doctors figure that out? Does it relate to Bayes' theorem?
If we connect this to the bigger picture, it underscores how clinicians are constantly making judgments about conditional probability. What's the chance of X given Y Bayes' theorem, a mathematical framework developed by Thomas Bayes, is the formal way to calculate this post-test probability by combining pretest probability, sensitivity, and specificity.
So doctors are doing complex math in their heads all the time.
Well, not explicitly calculating for every single decision, but they are implicitly, or sometimes explicitly, doing this Bayesian reasoning. They're weighing the prior likelihood against the new test information. It's a cornerstone of elite clinical thought.
And this leads us to another tricky area, right? Prevalence.
And this leads us to the critical concept of prevalence of disease, which clinicians, despite its critical importance, often neglect.
Neglect. How so?
Let me pose the Harvard problem mentioned in our source to you, the listener. Take a moment, maybe pause, and truly think about it. If a test to detect a disease whose prevalence is 1.1000 has a false positive rate of 5%, what is the chance that a person found to have a positive result actually has the disease, assuming you know nothing about the person's symptoms and signs?
Okay. Prevalence 1 in 1,000, false positive 5%. What's the chance a positive test is real? Gut feeling says pretty high, maybe 95% because the test seems okay. But the prevalence is low. Okay, I'll think. We'll come back to the answer later.
It's a tricky one. This problem removes the clinical context, forcing you to focus solely on prevalence and test performance. And it often trips people up, precisely because our intuition struggles with these numbers.
So prevalence really throws a wrench in the works.
It does. And this also brings us to another distinction. Predictive values, positive predictive value, negative predictive value, as seen in box 1.5, are different from post-test probability. While sensitivity and specificity are characteristics of the test itself and don't change regardless of the population, predictive values are calculated from a specific population.
Okay, so predictive values depend on the group tested.
Exactly. This is a critical limitation. You cannot simply transfer a predictive value calculated in one population to a different one because disease prevalence varies geographically and demographically. Published data on test performance may not apply to your patient.
So you can't just take a number from a study and apply it blindly.
Definitely not. Therefore, clinicians must anchor on the prevalence of disease in the subgroup to which the patient belongs, and then adjust to take the individual factors into account. This is the essence of smart, individualized decision-making, where the numbers meet the patient's unique reality.
Wow, that Harvard problem really makes you pause, doesn't it? It just goes to show how our intuition can sometimes lead us astray, which brings us perfectly to the next critical layer of clinical decision-making. The mind's own labyrinth of uncertainty and cognitive biases.
Yes, the internal challenges.
Because, as we've discussed, clinical findings are imperfect, diagnostic tests are imperfect, and clinicians are constantly grappling with uncertainty. While expressing uncertainty as a probability can help, subjective estimates of probability can sometimes be wildly unreliable.
Our internal probability meter isn't always accurate.
And this is precisely where intuition, for all its speed and efficiency, can become a surprising source of error. I want to challenge you, the listener, right now. Do you ever find yourself jumping to conclusions or going with your gut feeling before you fully thought something through? Our brains are wired for efficiency. Not necessarily for flawless logic in every scenario.
We all do it.
Let's try the bat and ball puzzle from our source. A bat and ball cost £1.10. The bat cost £1 more than the ball. How much does the ball cost? Don't solve it mathematically right away. Just listen to your intuition. What's the first number that pops into your head?
The classic.
Hold on to that answer. We'll come back to it at the end.
What's truly fascinating here and directly relevant to that puzzle is that there are two things going on in our brains when we make decisions. The first is what cognitive psychologists call dual process theory, which describes two distinct types of thinking, type 1 and type 2.
Okay, type 1 and type 2 thinking.
The second is simply that the human brain, for all its brilliance, is wired to jump to conclusions, to take shortcuts, or sometimes miss things that, in hindsight, seem obvious. Psychologist James Reason famously said, "Our propensity for certain types of error is the price we pay for the brain's remarkable ability to think and act intuitively."
So our intuition helps us, but also trips us up.
Precisely. This intuitive processing allows us to sift through constant sensory information quickly without having to laboriously analyze every new situation from scratch. And this property of human thinking is incredibly relevant to how doctors make decisions.
Tell us more about type 1 and type 2.
Let's delve into type 1 and type 2 thinking in more detail, as outlined in box 1.6 and figure 1.6. Type 1 thinking is our fast, automatic, intuitive mode. It's heuristic, meaning it relies on mental shortcuts and pattern recognition.
Gut feeling, pattern matching.
Exactly. It's subconscious, effortless, and highly affected by context and emotion. Think about driving a car once you're experienced. You don't consciously think about every micro movement or decision. It's automatic. If every decision were as deliberate and effortful as your first driving lesson, you'd never get anywhere efficiently.
Right, you'd be exhausted.
Expert decision-making in medicine, especially for familiar presentations, is often well served by this intuitive pattern recognition mode. However, its reliability can be variable, and it's vulnerable to error precisely because it's so quick and often bypasses deep analysis.
Fast and efficient, but prone to mistakes. What about type 2?
Type 2 thinking, in contrast, is analytical, systematic, and deliberate. It's conscious, slow, and effortful. This is when you meticulously weigh evidence, consider alternatives, and apply logical rules.
The slow, careful, logical mode.
Yes, it generally has high and consistent reliability, is less prone to error, and less affected by context or emotion, demanding high scientific rigor. This is the careful, reasoned approach.
So doctors use both.
The critical point for clinicians is that they use both, constantly shifting and interplaying in the diagnostic process, as figure 1.6 shows. When faced with a familiar problem, a clinician might quickly recognize a pattern and arrive at a working diagnosis using type 1 thinking, for example, a classic heart attack presentation.
Pattern recognition kicks in.
But for more complicated or ambiguous problems, they must shift into type 2, employing a slower, more systematic approach, evaluating all the evidence. While errors can occur in both types of thinking, our source emphasizes that the common cognitive biases encountered in medicine tend to occur when clinicians are engaged in type 1 thinking.
So the fast, intuitive mode is where biases often live.
That's where they often thrive, yes. This is because type 1 thinking, for all its efficiency, relies on shortcuts that, when misapplied, can lead to systematic errors.
Can you give examples of this interplay in action?
Let's look at two contrasting clinical examples from the source to illustrate this interplay and where errors can creep in. First, imagine being asked to see a drowsy young woman. You're told she has a history of depression and a packet of painkillers was found nearby.
Okay, seems like an overdose.
Your brain, using type 1 thinking, quickly identifies a pattern, probable overdose. At this point, a well-calibrated thinker engages in rational override, as shown in figure 1.6. They pause and consciously think, what is the concrete evidence for this specific diagnosis? What else could it be besides an overdose? Is there anything in her examination or history that doesn't quite fit?
So they step back and engage type 2.
Exactly. This deliberate, analytical step can prevent premature closure on the initial intuitive diagnosis.
Okay, that's rational override. What about the other example?
Now, consider the opposite scenario. Assessing a patient admitted with syncope or fainting. There are many potential causes, so a systematic type 2 approach is absolutely required. You diligently follow evidence-based guidelines, and it becomes clear the patient can be safely discharged.
Right, the slow, careful approach says discharge is safe.
But you recently heard about a dramatic case where syncope was caused by a leaking abdominal aortic aneurysm, ROPOA, a very rare but life-threatening condition. So despite the evidence, you decide to observe your patient overnight, just in case.
Letting that rare case influence you.
In this scenario, your intuition has led to an irrational override, again from figure 1.6. That recent, vivid, and memorable case has caused availability bias. Things that are easily recalled or recently encountered seem more probable, and it has distorted your probability estimate, leading to an unnecessary intervention based on a rare but compelling memory, overriding logical, evidence-based reasoning.
That distinction between rational and irrational override is fascinating, isn't it? It really highlights the constant internal battle.
It really does.
It's almost like our brains are hardwired for efficiency, and sometimes that efficiency leads us down a surprising rabbit hole. And that example of the syncope patient and availability bias leads us perfectly into a deeper dive on the common cognitive biases in medicine. Figure 1.7 lists quite a few.
Yes, it's quite the list.
Here's where it gets really interesting because these biases often don't work in isolation. They gang up on us, making the diagnostic landscape even trickier. Let's explore some of the most prevalent ones, complete with their definitions and vivid examples from our source.
Okay, let's go through them.
First up, anchoring. This is the common human tendency to rely too heavily on the very first piece of information offered that anchor when making decisions.
Latching on to the first thing you hear.
Imagine during handover, you hear a patient presented as having abdominal pain, probably just gas. That initial framing can deeply anchor your subsequent thinking, making it much harder to objectively consider and investigate more serious diagnoses.
You get stuck on gas.
Then there's diagnostic momentum. Once a diagnostic label has been attached to a patient, whether by the patient themselves, a previous doctor, or another healthcare professional, that label can gather momentum with each subsequent review.
It just keeps rolling downhill.
This often leads others to subconsciously exclude other possibilities in their own thinking, simply because a label already exists and seems to fit. It's hard to stop that train.
Very true.
Closely related is premature closure. This is the tendency to close the decision-making process prematurely and accept a diagnosis before it and other possibilities have been fully explored.
Jumping to conclusions too quickly.
It's that tempting, aha, I've got it moment. But unfortunately, sometimes you've gotten it wrong because you stopped looking for alternatives too soon.
Yeah, the aha can be dangerous.
Ascertainment bias means we sometimes see what we expect to see, a kind of self-fulfilling prophecy. The source gives a powerful example. A frequent self-harmer attends the emergency department with drowsiness. Everyone might immediately assume he's taken another overdose.
Because that's what usually happens.
And tragically, because of this expectation, they might miss a brain injury that's the true underlying cause of his drowsiness. They saw what they expected, and it blinded them to other possibilities.
Oh, that's worrying.
The psych-out error is a similar but distinct bias. This occurs when psychiatric patients who present with new medical problems are under-assessed, under-examined, and under-investigated simply because their new issues are presumed to be due to or exacerbated by their existing psychiatric condition.
Dismissing physical symptoms as all in their head.
Their legitimate medical complaint gets dismissed or trivialized due to a pre-existing label. The framing effect describes how the way a case is presented, for example, during a concise handover from one doctor to another, can inadvertently generate a significant bias in the listener.
How the story is told influences the listener.
This is why our source recommends always maintaining a healthy skepticism about other people's diagnoses until you've independently evaluated the evidence yourself. Don't just accept the frame.
Good advice.
Availability bias is exactly what we discussed with the syncope patient. This is when things are at the forefront of your mind because you've seen several similar cases recently, or perhaps you've been intensively studying a particular condition.
What's easily recalled seems more likely.
The source gives another relatable example. When one of the authors worked in an epilepsy clinic, suddenly all blackouts they saw seemed like possible seizures. Your recent, vivid experiences can disproportionately influence your probability estimates for new patients.
You see it everywhere.
Hindsight bias is a major problem, especially when learning from diagnostic error. Knowing the outcome of a case, for example, that a diagnosis was missed, can profoundly influence your perception of past events and decision-making leading up to that point.
The I knew it all along effect.
You might think, oh, it was so obvious, how could they have missed that? Even if it wasn't obvious at all at the time. This prevents a realistic appraisal of what actually occurred and tragically hinders true learning from mistakes.
Makes it hard to learn properly from errors.
Search satisficing means we might stop searching for alternative explanations or diagnoses simply because we found something that fits or is convenient instead of systematically putting in the effort to look for the best alternative.
Finding one answer and stopping the search.
It's about settling for good enough rather than best possible.
Convenient, but maybe not correct.
Base rate neglect is a crucial one, which we touched upon with the Harvard problem. It's the tendency to ignore the actual prevalence of a disease in the population, which then distorts our Bayesian reasoning.
Forgetting how common or rare something actually is.
For example, if you see a patient with symptoms that are common to a very rare disease, and you focus only on the symptoms without considering how rare the disease is, you might overestimate its likelihood. Sometimes clinicians do this deliberately to rule out an unlikely but worst-case scenario, which has its place, but it's a conscious distortion of probability.
Right, sometimes it's intentional, but often it's just overlooked.
Omission bias is the tendency towards inaction, often rooted in the noble principle of first do no harm. The idea here is that events that occur through the natural progression of a disease are seen as more acceptable than those that might be directly attributed to an action taken by the healthcare team.
Better to do nothing than risk causing harm by acting.
It's the thought process that says, better to do nothing and have a bad outcome than to act and cause a bad outcome, even if action might have led to a better result.
A difficult ethical line sometimes.
Triage queuing highlights how geography is destiny in some healthcare settings. Triage systems are designed to send patients to the right department. However, this can lead to bias.
Where you are influences how people think about you.
For example, a diabetic ketoacidosis patient with abdominal pain and vomiting might be sent to surgery. Once on a surgical ward, the setting itself can stop people from thinking about medical causes of abdominal pain and vomiting, simply because they're in a surgical environment, leading to a missed medical diagnosis.
The environment frames the thinking.
Conversely, commission bias is the tendency towards action rather than inaction, operating on the assumption that good can only come from doing something, rather than adopting a more cautious, watch-and-wait approach.
The urge to do something, even if waiting is better.
It's the urge to intervene, sometimes unnecessarily.
Action bias.
Overconfidence bias is probably one we can all relate to, in and out of medicine. It's the tendency to believe we know more than we actually do, placing too much faith in our own opinion instead of diligently gathered evidence.
Thinking you know best, despite the evidence.
Our source points out that this bias can be augmented by availability bias, thinking you're an expert because you've seen a few memorable cases, and commission bias, the urge to act decisively, sometimes with disastrous results. It's a powerful combination.
A dangerous mix.
The unpacking principle describes the failure to unpack all available information, which can mean crucial details are missed. For example, if a truly thorough history isn't obtained from either the patient or their carers.
Not digging deep enough for the full story.
Important diagnostic possibilities might be entirely overlooked or discounted simply because the information wasn't elicited in the first place. Common in geriatric medicine, for instance. Confirmation bias is the tendency to look for confirming evidence to support a pre-existing theory, rather than actively seeking disconfirming evidence to refute it, even if that disconfirming evidence is clearly present.
Looking for proof you're right, ignoring proof you're wrong.
This is particularly common when a patient has been seen first by another doctor, and you're subconsciously trying to confirm their initial assessment rather than objectively reevaluating the patient from scratch.
Yeah, it's easy to fall into that trap.
Posterior probability refers to how our estimate of the likelihood of a disease can be unduly influenced by what has gone on before for a particular patient.
Letting the past overly influence the present assessment.
For instance, if a patient has been extensively investigated for headaches in the past, their new severe headache might lead clinicians to discount serious causes, assuming everything serious has already been ruled out, even if the current presentation is different.
We already looked into that.
And finally, visceral bias is the subtle, often subconscious influence of either negative or positive feelings towards patients, which can subtly, or not so subtly, affect our decision-making.
How you feel about the patient affects your judgment.
If you have a particularly good rapport with a patient, you might be more thorough, or conversely, if a patient is perceived as difficult, you might inadvertently be less so. It's a very human, but potentially dangerous aspect.
It is. These biases are everywhere.
It's quite a rogues gallery of mental shortcuts, isn't it?
Oh.
The source concludes this section by emphasizing that the mark of a well-calibrated thinker is the ability to recognize what mode of thinking is being employed, and to anticipate and recognize situations in which cognitive biases and errors are more likely to occur.
It really comes down to self-awareness, constantly thinking about thinking.
Exactly.
Recognizing these internal cognitive traps is the crucial first step towards elite decision-making. But clinical decision-making doesn't happen in a vacuum. It's heavily influenced by the work environment and team dynamics. This brings us to human factors.
Okay, the external influences now.
Human factors is essentially the science of understanding the limitations of human performance and how technology, the work environment, and crucially, team communication can be adapted to reduce diagnostic and other types of error.
Making the system work better for humans.
Precisely. Analysis of serious adverse events in clinical practice consistently shows that human factors and poor team communication play a significant, often central role when things go wrong. Research has clearly demonstrated that many errors are actually beyond an individual's conscious control and are precipitated by a multitude of factors in their environment.
So it's not always just the individual's fault.
Often it isn't. The discipline of human factors seeks to understand the complex interactions between three key areas: people and their tasks or technology,
Like how easy is the equipment to use?
people and their work environment,
Noise, interruptions, chaos.
and people in a team.
How well do they talk to each other?
Exactly. An understanding of these interactions is crucial for healthcare professionals who are inherently committed to the principle of first, do no harm to work in the safest way possible. For example, performance is demonstrably adversely affected by things like poorly designed processes and equipment, frequent interruptions in a busy ward, and perhaps most importantly, severe fatigue and sleep deprivation,
Ah, yes, tired doctors.
which are unfortunately common in medical training and practice. Figure 1.8 in our source illustrates some of these internal factors like knowledge, stress, sleep, and external ones like time pressure, interruptions, insufficient data that affect human judgment.
So fatigue is a big one. How does that link back to type 1 and 2 thinking?
When you're fatigued or under significant cognitive overload, say, trying to manage multiple sick patients at once, the areas of the brain required for type 2 processing that slow, analytical, effortful thinking are most affected.
The careful thinking part gets tired first.
Your brain, trying to conserve energy and cope, reverts to type 1 processing, increasing your vulnerability to cognitive errors. This is a powerful, almost unavoidable survival mechanism, but one that can be dangerous in a clinical setting where precision is paramount.
You default to the faster but potentially more error-prone mode.
We also have a natural tendency, demonstrated in various experiments, to focus our attention, filtering out distractions to concentrate. While this is advantageous in many situations, allowing us to concentrate deeply on a primary problem, it can also lead us to miss the unexpected, to overlook things that aren't immediately in our field of focused attention.
Tunnel vision.
Imagine a doctor intently focused on a patient's breathing, missing a subtle skin rash that points to a different underlying condition. And in a team context, what might be glaringly obvious to one person could be completely missed by someone else. Therefore, safe and effective team communication absolutely requires us never to assume anything and to verbalize things, even though they may seem obvious.
Say it out loud, even if you think everyone knows. Making the implicit explicit is key to patient safety and error prevention.
So we've dissected the problem, from the inherent imperfections of tests to the sneaky ways our own minds and our environment can trip us up. The critical question now becomes, so what does this all mean for making better decisions?
Right, how do we combat all this?
How do clinicians, particularly those operating at an elite level, actually mitigate all these risks and reduce those alarming diagnostic error rates? Our sources are clear. Simply having more knowledge and experience doesn't eliminate errors.
Experience isn't enough on its own.
Instead, there are a number of proactive, strategic ways to reduce errors in clinical decision-making. These broadly fall into three main categories: adopting cognitive debiasing strategies, effectively using clinical prediction rules and other decision aids, and ensuring truly effective team communication. Okay, let's delve into each of these strategies in detail, as these are the tools of the trade for elite professionals. First, the cognitive debiasing strategies. These are established techniques designed to help clinicians avoid those pervasive cognitive biases and errors we just discussed.
Ways to consciously fight the biases.
The first one might seem obvious, but its importance is paramount and often underestimated. Thorough history and physical examination. It's sometimes carried out inadequately, and this is precisely where the unpacking principle comes into play.
Back to basics, but doing them properly.
Failing to unpack all available information, meaning not asking enough pertinent questions, not exploring every symptom, or not being thorough enough in the physical exam, means crucial details can be missed. This directly leads to knowledge gaps and subsequent errors. Thoroughness is not just about ticking boxes, it's a primary debiasing strategy that ensures a complete data set.
Okay, be thorough. What else?
Next, the disciplined use of problem lists and differential diagnoses. Once all the data from the history, physical examination, and initial test results are available, they need to be synthesized into a coherent problem list.
Listing out all the issues clearly.
The ability to identify key clinical data and create this list, prioritizing what's most urgent or potentially life-threatening, is a fundamental step in clinical reasoning. Some problems might just require a straightforward action, like a low potassium requiring supplementation, but others, like persistent vomiting or chest pain, demand a robust differential diagnosis.
Thinking through all the possibilities.
The rigorous process of generating a problem list ensures nothing is missed, acting as a safeguard. And the act of generating a broad differential diagnosis specifically works against biases like anchoring on a particular diagnosis too early, thereby avoiding search satisficing and premature closure. It forces a broader, more systematic view.
Forces you to think wider. Makes sense.
Mnemonics and checklists are also heavily used in medicine to reduce reliance on fallible human memory, especially under pressure. The ABCDE mnemonic, airway, breathing, circulation, disability, exposure examination, is arguably the most successful and widely adopted checklist in medicine.
ABCDE, yeah, you hear that a lot in medical dramas even.
Used universally during the initial assessment and treatment of critically ill patients. These mnemonics and checklists ensure that all important issues have been considered and completed, which is especially vital under conditions of complexity, stress, or fatigue when type 1 thinking might otherwise lead to omissions. They provide a structured, reliable backbone.
Structure helps prevent missing things under pressure.
Then we have red flags and rows, rule out worst case scenario. These are powerful strategies that force doctors to actively consider serious diseases that can present with common, innocuous symptoms.
Actively thinking. What's the worst this could be?
For example, actively considering and investigating for a possible pulmonary embolism, PE, in patients presenting with seemingly simple pleuritic chest pain and breathlessness is a common application of rouse, because PE can be rapidly fatal if missed, despite its common symptoms. These strategies directly help to avoid the framing effect and premature closure. They ensure a disciplined consideration of the most dangerous possibilities.
Keeps the scary stuff on the radar.
It's worth noting that newer strategies are continuously emerging to avoid these cognitive biases and errors. These include explicit training in clinical reasoning and human factors, directly teaching doctors how to think about their thinking, to recognize their own biases, and take proactive steps to mitigate them. It's about training the mind itself.
Metacognition training. Interesting. What's the second category of strategies?
The second major strategy involves using clinical prediction rules and other decision aids. A clinical prediction rule is essentially a statistical model of the diagnostic process, taking multiple factors, symptoms, signs, test results, and assigning them numerical weight to calculate a probability.
Using scores and models to help guide decisions.
What's truly compelling here is that when these rules are objectively compared against the opinion of experts, the statistical model often outperforms the experts.
Really? The rule beats the expert.
Often, yes. Why? Because the rule is applied consistently in each and every case, without the influence of human biases, fatigue, or the gut feeling that can sometimes be wrong. However, it's crucial that these rules are used correctly, meaning they must be applied to the specific patient population that was used to create and validate the rule.
Consistency beats potentially biased intuition, but you have to use the right rule for the right patient.
Precisely. They force a scientific numerical assessment of a patient's data to develop a numerical probability of a disease or an outcome, thus helping clinicians estimate probability more accurately and objectively. Good examples that are widely used include the Wells score for suspected deep vein thrombosis,
Okay.
or the Gray score for acute coronary syndromes, which predicts patient outcomes. Similarly, the CURB-65 score for community-acquired pneumonia helps predict outcomes and informs treatment decisions, like whether a patient needs hospital admission.
So these scores provide objective risk levels.
Exactly. And the third crucial strategy.
The third strategy, effective team communication.
This is absolutely vital for safe clinical care, particularly during handovers from one shift to the next or when referring a patient to another specialist. The SBAR system, Situation Background Assessment Recommendation, is a structured, universally adopted way to communicate about a patient.
SBR, Situation Background Assessment Recommendation.
Recommended by campaigns like the UK's Patient Safety First. It increases the amount of relevant information communicated in a shorter, more organized, and unambiguous time. For instance, in a telephone call to an intensive care team, Box 1.7 shows how SBR guides the call. Situation: I am name calling from place about a patient with a NINDU-DAVETS of 10, a deterioration score. Background: patient's name, 30-year-old woman, no past history, admitted last night with pneumonia. Her oxygen needs are increasing. Assessment: her vital signs are. Specifics. Recommendation: please come see her urgently. I think she needs ICU admission.
Very structured, clear communication. Avoids rambling or missing key info.
Precisely. And in increasingly complex healthcare systems, patients are looked after by many different professionals, each holding a piece of critical information. Strict hierarchies where junior staff or nurses might feel unable to speak up are hazardous to patient safety.
Everyone needs to feel they can speak up if something seems wrong.
It's crucial for all members of the team to be able to voice concerns or observations, regardless of their position in the hierarchy, without fear of reprimand. This culture of psychological safety is fundamental for error prevention.
All those strategies are about making the process more robust and less susceptible to human error. But ultimately, all these decisions come back to one central figure: the patient.
Absolutely.
And that brings us to patient-centered evidence-based medicine and shared decision-making. Patient-centered EBM means applying the best available research evidence, yes, but crucially, it also means taking individual patient factors into account.
Bringing the evidence and the individual together.
This isn't just about their clinical status, their diseases and symptoms, but also non-clinical aspects, things like their social circumstances, their personal values, their wishes for their care, and their personal preferences, including their tolerance for risk.
The whole person, not just the disease.
Consider this challenging example from our source, which perfectly illustrates the complexity. A 95-year-old man with dementia and a recent gastrointestinal bleed is admitted with an inferior myocardial infarction. He is clinically well. Should he be treated with dual antiplatelet therapy and low molecular weight heparin as recommended in clinical guidelines?
Wow, yeah, that's a tough one. Guidelines say treat the heart attack aggressively.
But for this specific patient, 95 years old, with severe dementia and a recent major bleed, those powerful anti-clotting medications might cause a fatal new bleed, despite potentially helping his heart.
The treatment could be worse than the disease in his specific context.
This isn't a simple yes or no from a textbook. It requires a deep, nuanced discussion weighing the statistical evidence against this particular patient's unique context, his quality of life, and his or his family's expressed goals for his care. It's where the art and science truly meet.
This raises an incredibly important question. How do clinicians explain risks and benefits to patients in an accurate and crucially understandable way?
Yeah, translating complex stats is hard.
Providing relevant statistics alone is often insufficient to guide decision-making, because a patient's perception of risk can be profoundly influenced by what our source calls irrational factors, as well as their deep-seated individual values. For example, one person might prioritize living longer at all costs, even with significant side effects, while another might prioritize quality of life, even if it means a shorter lifespan.
Different people value different things.
To make statistics more comprehensible and less abstract, the practical advice is for clinicians to quote numerical information using consistent denominators. Instead of vaguely saying a small risk of stroke and a rare chance of death, which is nebulous and unhelpful.
Which means almost nothing, really.
They should say something like, out of every 100 patients who have this operation, 90 will feel much better, 1 will die during the operation, and 2 will suffer a stroke. This provides a clear, consistent frame of reference, making the probabilities concrete and relatable.
Using X out of 100 makes it much easier to grasp.
For complex statistical information, visual aids, like Figure 1.9 from our source, showing outcomes as simple blocks of people, can be incredibly helpful to make the abstract concrete and aid patient comprehension.
Pictures help too.
Ultimately, how uncertainties are conveyed to patients and how genuinely their preferences are incorporated into the decision is paramount. Numerous studies correlate effective clinician-patient communication and shared decision-making with significantly improved health outcomes.
Better communication equals better outcomes.
When patients feel they have been truly listened to, genuinely understand their problem, the range of possible treatments, and the proposed plan, they are far more likely to follow that plan, leading to better adherence to medication and lifestyle changes, and are less likely to reattend the hospital with recurring or worsening issues.
It builds trust and empowers the patient.
It builds profound trust and empowers the patient to be an active participant in their own care. This is the hallmark of truly elite, patient-centered medicine.
That's a powerful way to think about the human element in medicine, transforming raw data into meaningful choices for the individual. Now, let's bring it all together. We've covered a lot of ground today.
We certainly have.
From the inherent imperfections of clinical skills and diagnostic tests to the insidious influence of cognitive biases and the critical importance of human factors in the demanding healthcare environment. To truly master this information and solidify your understanding like an elite professional, we're going to walk through a comprehensive patient case, applying all the concepts we've discussed in real-time clinical decision-making.
Okay, let's see it in action.
So imagine this scenario. A 25-year-old woman presents with right-sided pleuritic chest pain that's pain that worsens sharply with breathing and breathlessness. She reports she had an upper respiratory tract infection a week ago and was almost back to normal when these new symptoms started.
Okay, young woman, sharp chest pain, breathlessness.
She has no past medical history of significant illness, no family history of blood clots, and her only medication is the combined oral contraceptive pill. On examination, her vital signs are all within normal limits. Respiratory rate 19 breaths min, oxygen saturations 98% on air, blood pressure 11 to 560 millimol Hg, heart rate 90 beats min, and temperature 37.5 degrees C. Her physical examination is also completely normal, no leg swelling, no crackles in her lungs.
Normal exam, normal vitals, except maybe the heart rate is borderline. Pill's a small risk factor.
You, the doctor, have been asked to assess her for the possibility of a pulmonary embolism, or PE, a potentially life-threatening blood clot in the lung.
All right, let's walk through the exact thinking process an elite clinician would undertake for this patient, applying all the principles we've discussed. First, we apply evidence-based history and examination.
Okay, what does that tell us here?
We acknowledge that pleurisy and breathlessness are common features of pulmonary embolism, but they're also very common in many other less serious conditions like viral pleurisy or muscle strain. There's nothing in her history to suggest an obvious alternative that fully explains her current presentation.
No clear alternative cause jumps out.
Her vital signs are normal, and her physical examination is normal. But here's the crucial point, linking back to our discussion on likelihood ratios. The source highlights that the only feature in history and examination that has a negative likelihood ratio for pulmonary embolism, meaning it meaningfully decreases the probability, is a heart rate of less than 90 beats per minute.
And hers is exactly 90, so it doesn't help rule it out.
Exactly. In other words, her otherwise normal physical examination findings, including normal oxygen saturations, actually carry very little diagnostic weight in excluding a PE. This is where that counterintuitive lesson about LRs comes to the forefront. A normal exam doesn't necessarily mean no PE.
So despite looking well, PE is still definitely on the table. What next? Pre-test probability.
Next, deciding pre-test probability. We need to anchor on the prevalence of disease. In healthy 25-year-old women, the general prevalence of pulmonary embolism is relatively low. We then adjust for individual patient factors. This patient has no major risk factors for PE like recent surgery, immobility, or cancer, except being on the combined oral contraceptive pill, which slightly increases risk but doesn't elevate her to a high-risk category.
So low prevalence, one minor risk factor.
To assist our estimate objectively, we use a clinical prediction rule, the modified Wells score for pulmonary embolism. Applying this, she would likely score 3, only answering yes to the criterion. PE is the #1 diagnosis, and alternative is less likely because her symptoms, while nonspecific, are concerning for PE, and there's no clear alternative. This score places her in the low probability category for PE.
Okay, the score confirms. Low pretest probability. Now for tests.
Now, interpreting test results. Imagine she goes on to have a normal chest x-ray and normal general blood results, apart from one key finding, a raised D-dimer of 900 ng/ml, whereas normal is typically less than 500 ng/ml.
Okay, X-ray normal, but D-dimer high. What does that mean?
A normal chest x-ray is common in PE, so it doesn't rule it out. Here's where the D-dimer comes in. The D-dimer assay has at least 95% sensitivity for acute pulmonary embolism, meaning it's excellent at detecting the presence of a clot, but it has very low specificity.
Right, sensitive but not specific. Good rule-out test.
Exactly. So a negative result would virtually, though not completely, exclude a PE. However, a positive D-dimer, like hers, does not mean this patient has a pulmonary embolism. It just means that we have not been able to exclude it.
So the positive D-dimer just keeps PE in the running, it doesn't confirm it.
Correct. Because pulmonary embolism is potentially fatal, even with a low pretest probability, we need to apply Rao's rule-out worst-case scenario. Therefore, the next crucial step is to arrange further definitive imaging, like a CT pulmonary angiogram, CTPA.
Got to do the scan to be sure, because missing it is too dangerous. What about treatment in the meantime?
This brings us to the treatment threshold. What if the CTPA can't be performed until the next day due to scanner availability or the time of night? This is a common real-world dilemma.
Happens all the time, right?
Because pulmonary embolism is potentially fatal, and the risks of starting treatment in this case, anticoagulants, are relatively low for a healthy 25-year-old, the patient should be started on treatment while awaiting the scan. This demonstrates how the balance of risks and benefits, coupled with the severity of the potential diagnosis, influences the threshold for starting therapy, even before definitive confirmation is available.
Treat first, confirm later, because the risk of waiting is too high.
You act on the probability, not just the certainty.
Okay, so she gets to the scan. What's the post-test probability?
Later, the post-test probability. Let's say her CTPA scan result comes back as no pulmonary embolism. Combined with the initial low pretest probability and the clinical assessment, this definitive negative scan result reliably excludes pulmonary embolism. The combination of low pretest probability and a robust negative confirmatory test makes the diagnosis of PE extremely unlikely.
Okay, so low probability to start, negative scan confirms it's very unlikely. Now, how could biases mess this up?
Now let's inject some cognitive biases into this exact case to see how easily errors can creep in. Imagine during a quick handover from another doctor, the patient was simply described to you as nothing wrong, probably a pulled muscle.
The framing effect right away.
Immediately, cognitive biases would come into play. The framing effect could make you think only of musculoskeletal pain, anchoring your subsequent thoughts. Confirmation bias might then subtly lead you to unconsciously look only for evidence that supports that muscle strain diagnosis, ignoring other cues. And search satisficing might make you stop searching for other possibilities once you've settled on that benign explanation.
You just look for proof it's a muscle pull and stop there.
And the normal clinical examination, which we now know actually carries little diagnostic weight for excluding PE, might then falsely confirm musculoskeletal pain in your mind, despite no history or physical findings like chest wall tenderness to actually support a musculoskeletal cause.
So bias makes you misinterpret even the normal findings. What about human factors?
And for human factors, picture this. You've just seen the patient. You're busy with multiple other tasks, perhaps feeling the effects of a long shift. A nurse rushes up, hands you some blood forms, and asks what tests you'd like to request on this lady. Distracted under pressure, you quickly request blood tests, including a D-dimer, but you accidentally sign the forms for the wrong patient who is sitting in the next cubicle.
Oh no. Simple mistake, big consequences potentially.
Luckily, in this hypothetical, this error is intercepted by another system check. Perhaps a vigilant phlebotomist notices the patient's name doesn't match the request, or the lab system flags an unusual request for that patient. This highlights how systemic checks and clear, unhurried communication can mitigate human factors errors and prevent potentially serious diagnostic delays or incorrect treatments.
Systems can catch individual errors. So how did the elite approach avoid these errors?
So reducing cognitive error in this difficult diagnosis of pulmonary embolism involves combining several strategies we discussed, as demonstrated by an elite clinician, using the modified Wells score as a clinical prediction rule to objectively estimate pretest probability, consulting evidence-based guidelines like those from the UK's BICC for management, and utilizing decision aids like the Simplified Pulmonary Embolism Severity Index, PSI, to assess risk.
Using the rules, guidelines, scores.
All of these structured analytical approaches are used in combination with the doctor's seasoned clinical opinion, derived from a thorough, evidence-based history and physical examination. It's integrating the tools with the clinical judgment.
Finally, how do you communicate this back to the patient?
Finally, person-centered EBM and information given to the patient. This patient was treated according to evidence-based guidelines that applied to her specific situation, balancing the need to rule out a serious condition with the risks of over-investigation. At the end of this process, she's told that the combination of her history, examination, and all the test results means she's extremely unlikely to have a pulmonary embolism.
Clear communication of the low likelihood.
An alternative, more benign diagnosis like viral pleurisy is offered to give her an explanation for her symptoms. She is then reassured that her symptoms are expected to settle with simple analgesia and is given clear, actionable advice to represent to the hospital immediately if her symptoms suddenly worsen.
Give an alternative explanation, reassure, and provide safety netting.
It's about clear, empathetic communication, comprehensive reassurance, and proper safety netting, putting the patient's understanding and well-being at the very center of the entire complex process.
That case study truly brought all those complex layers to life, showing how clinicians navigate the vast ocean of information and uncertainty every single day. We've come a long way in this deep dive.
They have indeed.
From defining clinical reasoning and uncovering the surprising prevalence of diagnostic errors, to understanding the intricate nuances of diagnostic tests, and perhaps most importantly, exploring the surprising and often subconscious ways our own minds can mislead us through cognitive biases.
It's a complex interplay.
It's clear that clinical decision-making is this incredible dynamic interplay of deep knowledge, honed clinical skill, sometimes flawed intuition, and systematic, disciplined thinking, all constantly navigating degrees of uncertainty. And if you, our listener, have grasped these concepts with us today, you truly have an understanding that rivals the elite professionals in this field. You've gone beyond the what to understand the how and the why.
Hopefully providing a useful framework.
Before we wrap up, let's revisit those puzzles, which so powerfully illustrate the pitfalls of intuition versus rigorous thought. Remember the bat and ball puzzle. A bat and ball costs £1.10. The bat costs £1 more than the ball. How much does the ball cost? Your intuition likely screamed 10p, didn't it?
It's the immediate, easy answer.
Well, as Nobel laureate Daniel Kahneman writes, the distinctive mark of this easy puzzle is that it evokes an answer that is intuitive, appealing, and wrong. Do the simple math. If the ball is 5p and the bat costs £1 more, then the bat is £1, so 5. Together, they total £1.10. The correct answer is 5p.
The intuitive answer is wrong. It takes type 2 thinking to get it right.
And then the Harvard problem. If a test to detect a disease whose prevalence is 1 pound in 1,000 has a false positive rate of 5%, what is the chance that a person found to have a positive result actually has the disease, assuming you know nothing about the person's symptoms and signs?
The prevalence trap again.
This is the prevalence trap. Almost half of doctors surveyed got this wrong, often saying 95%, but they neglected to take prevalence into account. If you test 1,000 people, on average, only one actually has the disease. However, with a 5% false positive rate, you will have 50 healthy people testing positive. 5% of the 999 healthy people is roughly 50.
So lots of false positives because the disease is so rare.
So out of all the positive results, you'll have 51 total. 50 false positives and 1 true positive. The chance that a person found to have a positive result actually has the disease is therefore 1 out of 51, or roughly 2%.
Only 2%. Hugely different from the intuitive 95%. It powerfully reinforces the importance of prevalence and the dangers of ignoring it.
Absolutely.
If we connect this to the bigger picture, it's a profound reminder of the immense responsibility involved in making decisions where lives are literally at stake. And understanding these principles of clinical decision-making, acknowledging the inherent uncertainty and the omnipresent human element, should fundamentally change how you perceive news about medical errors.
Yeah, it's rarely simple blame.
It's rarely about malice or incompetence, but often about incredibly complex interactions between cognition, environment, human limitations, and the inherent imperfections of diagnostic tools. It also challenges you to consider your own everyday decisions where uncertainty and intuition play a role.
How biases affect us all.
How does recognizing your own cognitive biases in daily life, whether it's evaluating news headlines, making financial choices, or even simply interpreting someone's intentions, empower you to make more informed choices? What specific steps can you take to apply that concept of thinking about thinking in your own pursuits, to consciously engage your type 2 system and perhaps avoid a few bat and ball moments in your own life?
Something to mull over.
Something to mull over until our next deep dive.